All right, well, hello. I'm impressed you guys are here at 6 o'clock. I didn't think anyone would come. My name is Deepa. I'm one of the endocrine attending. I recognize somebody. Soon. So I'm doing, I guess, the endocrine board review here. And most of these slide sets are questions taken from MixApp, and I'm just hoping to highlight some things that you'll probably see on the board, because I don't think a comprehensive endocrine review is probably possible in this time period. So this made me a little bit sad. I looked through last year, then I kept looking, and then I looked again, and then I got 2005, and it's the same from 2005 to present on the in-service. I think this reflects more us than you guys, obviously, because you score fantastically overall on everything else. So this in rheumatology fared pretty poorly. It's obvious that we're outpatient specialties, and most of what you see in the hospital is not what we do on a daily basis. So but the flip side of it is it's actually really easy to learn. I do think that it is high yield. I looked at the old MixApp and the current questions and the category breakdowns. It's actually really high yield. You know, a lot of the board's questions I think are annoying because they ask, what's the next best step? And you clearly know how to take care of patient X, and you would probably do all three things at the same time, and you're not sure which one to pick. But for most of the endocrine questions, they're really straightforward. There's such bizarre scenarios like Cushing's or pituitary disease that essentially they give you a big paragraph, and at the end of it, they just want to know what the diagnosis is. So if you really just study a couple of basic algorithms, I think you'll be okay for endocrine boards, because you guys know diabetes, I think. It is a lot of the exam. It's about 8% of the exam, the large majority of which is diabetes. Lipids I'm not going to cover, because I figure you do it in cardiology. Thyroid and calcium are the big other categories, and that represents pretty much what we see in the outpatient settings. The reason I put those little stars by the adrenal and pituitary is, again, because they're really easy to learn as far as internal medicine board review level. It doesn't take a lot of time, and you'll get all those answers right if you just do those algorithms. So I'm actually going to go backwards. I'm going to start with pituitary and then adrenal. So I think people get a little more confused as to how to work up those problems, and go this way. And if we don't get to the diabetes slides, you can figure those out on your own. Okay, so pituitary. So this is just a reminder that most of the things in the pituitary that we talk about come from the front of the pituitary, the anterior pituitary gland. The posterior pituitary, literally ADH is all you have to worry about. Too much is SIADH, and then too little is what we see in endocrinology, which is diabetes insipidus. Okay. So the anterior pituitary produces all of these hormones, which in turn target the end organs. I put a red box around prolactin because it is the most common endocrine board question that you will get, because it's seen in primary care practice, seen in GYN a lot. You know, hyperprolactinemia is fairly common in oligomenorrhea, amenorrhea. All right, so pituitary pathology, I think, can be subdivided broadly into tumors, and then hypofunction, which can occur for a lot of reasons. And then finally, as in every single endocrine organ, pituitary incidentalomas, you need to know how to work up every incidentaloma. They're actually not that hard either. So in terms of adenomas, remember that most of them, I shouldn't say that, most of them are functioning, and a third of them are non-functioning. Some theories say they're half and half. The most important thing is if it's a functioning tumor, it's most likely going to secrete prolactin. Acromegaly or growth hormone secreting tumors are next. And then these things are really rare. You will not get any questions about TSH secreting adenomas, because that would be really mean. We barely get them on endocrine boards. But these two things you should definitely know. And Cushing's, there's a disproportionate amount of questions on Cushing's on the boards, and I'm not sure why. I think it's always been that way. And the non-functioning tumors we're finding out aren't truly non-functioning. Most of them stain for these two things. But in terms of clinical terms, patients present as if they're not making extra hormones. You don't present like you have extra testosterone or estrogen, but that's just what they stain for. So why do we care about them? If they get big enough, they'll impinge upon your optic nerve or optic chiasm, and they can interfere with normal pituitary function. So you can become hypopituitary. And then if you make too much of one of these abnormal hormones, you get a clinical syndrome. There are lots of ways you can become hypopit. You can, again, have a large tumor that's grown. Most of the time we do it to patients, and most of the people in our clinic have had transsphenoidal surgery. Maybe they have radiation for non-endocrine diseases that affects the pituitary. These are not that commonly seen in real life, but they show up a lot on the boards. There's a lot of women who had massive hemorrhage and then never lactated and then go on to be tired and lose their hair and become hypopit, and they show up a lot on the boards. I don't know why. But she just refers to pituitary hemorrhage that occurs after pregnancy the pituitary gland gets very big in pregnancy because there's a prolactin production. There's a lot of blood flow to the anterior pituitary, and then if you happen to hemorrhage and lose that all of a sudden, you can get pituitary necrosis. Apoplexy is kind of the same thing. It's just a large pituitary adenoma that suddenly loses its blood supply. People can present with really bad headaches and syncope, so that's kind of, I guess you guys have to think about other things like meningitis and subarachnoid hemorrhage, but in the endocrine world, bad headache is apoplexy, and that's on your differential. Diabetes insipidus almost never results from these things. No matter how big your tumor is, it's really hard to get to the posterior pituitary, so it's usually from surgery. We do it to people, and sometimes it's idiopathic. And then we'll talk about how to work up the incidentalomas. 1 centimeter is the cutoff for micro versus macro in the pituitary. The importance being that most micros are not going to grow and cause mass effect. I mean, we follow them, we do MRIs, but the vast majority of them are never going to cause mass effect, but they can secrete things, and that's why they're concerning. And then macros, you have to worry about all the stuff that we talked about, secretion as well as hypofunction. Okay, so this is kind of my classic example of a really long question that doesn't even need to be read, and then you can figure out what the answer is. So this is a woman who is 58. She has fatigue, weight gain, and headache, has not been seen for a while, and was told that she had, or you were told that she has a remote history of a pituitary macroadenoma who already had treatment. Okay, and so just skip all this stuff and go down there and ask which of the following is the most likely cause of the patient's findings. So you don't even know what her findings is, but you know you have clearly a person who's probably going to be asking about hypopit. Maybe tumor recurrence, so if she had the whole thing taken out and then radiated, it's unlikely it came back. So then you can kind of go back and skim the rest of the paragraph. So she has no clue what really happened to her, but it all happened many years ago. And that's kind of an important thing, too. Remember, surgery affects the pituitary right then and there, but if you radiate the pituitary, the person can be fine for years and years. And at the 10-year mark, almost everyone's hypopit. So these are folks you have to follow every year and keep bringing them back to clinic and do your cosentropin test. And half the time you're not doing anything for them, but you bring them back a year later anyway. So that's the issue with radiation. So she was healthy, and then recently she's got all these symptoms of fatigue, weight gain, headaches, dry skin. So basically a bunch of hypothyroid symptoms, some nausea, and then on exam they tell you she's pale, she has edema. So they just keep telling you that she's hypothyroid in very many different ways. And then, thankfully, her pituitary MRI shows nothing. So this is not recurrence of tumor. These are all hypopit symptoms. Okay? And if you're really not sure what your answer is yet, here's your laboratory studies. She has dilutional anemia. She has a very low morning cortisol. Everything's low. Her FSH, her LH, her prolactin, her TSH, her free T4 growth, everything is low. Okay, so you could have just picked one or two parts of the scenario and answered it and just gone on. So the answer here is which one? D, yeah, panhypopit. I don't really think any of them. And so primary hypothyroidism is the one thing that I caution you. If you skimmed it really quickly and saw a TSH of 0.2, you may say that it's primary hypothyroid. I see one of these at least once or twice a year, someone who didn't really tell their primary care physician their pituitary history and was on Synthroid for panhypopit and had a free T4 that was normal, but a TSH that was undetectable, and they keep lowering the Synthroid, and always the TSH is still undetectable. And then they come back to see me finally a year later, and they're bloated, and their heart rate is 45, and they're losing their lateral hair, because a TSH will always be 0 if you have pituitary hypothyroidism. So that's not a big deal in this question, but in future questions it might be. Okay, so here's the headache man. 50-year-old man with acute onset of headache. And then I put the most important things here. He has visual field testing with left hemianopsia and ptosis. His eye is down and out. So you remember which cranial nerve? 3, yeah. You can guess. It's usually one of those 3, but it is cranial nerve 3. So his cranial nerve is affected. He has a bad headache. It was sudden. And then his vitals show a little bit of a fever. Blood pressure is kind of bizarrely with very low pulse pressure. He's tachycardic. He's confused. And then his lab studies just show a low sodium. So I guess this is not really fair because there's probably lots of things in this differential. You don't know that you have an endocrine question when you're taking the board. But I'm guessing there would be more things that they would tell you either focally or lab-wise if it was a meningitis or a hemorrhage. This is the kind of a classic presentation of pituitary apoplexy. It's more often in men than in women, and we think it's because women, particularly young women, lose their periods pretty early on no matter what kind of pituitary tumor they have. So men can grow to have very large prolactinomas or any kind of secreting tumors before they lose their testosterone. So it's a medical emergency. They need steroids right away, and then everything else can wait, okay? And lots of fluids. So this is another tired woman who's gaining weight. This is like my entire clinic. But there, okay, and she's also constipated. She has a history of craniopharyngioma. So you guys remember where that is? So it's above the pituitary. It's a suprasellar mass, has a bimodal peak. So kids get it, and then people in their 50s and 60s get it. And it's different from pituitary tumors, which cause anterior pituitary insufficiency. This can cause posterior pituitary insufficiency as well. DI is a common presentation because it's above the whole pituitary, and it's affecting the stalk that sends ADH from the brain down to the pituitary. Okay, so she tells us she's hypopit, has DI after her treatment. They give you all her medications, which is essentially the list for a pan-hypopit patient. And she feels fine. She's having regular periods on her birth control. And then there's her lab studies. Okay? So what should we do to her therapy? And she's complaining of fatigue, weight gain, and constipation. Thoughts? See, there we go. So much smart. Yeah, so that's good. So again, they don't want you to, there's a lot of these on the boards, interestingly enough, but they don't want you to think that this means she has under-replaced, which would be the case if she had primary hypothyroidism, over-replaced. Okay. All right, so this is polyuria and polydipsia. So no endocrine history, just polyuria, polydipsia. So those two things alone, most often in your world, it's going to be plain old diabetes. But in the non-diabetes world, polyuria and polydipsia is from drinking too much, as in your psych patients. Or in my world, too much ADH or ADH resistance at the level of the kidney. Okay, so there's not a whole lot for polyuria and polydipsia. There's your big differential, so hypercalcemia and all the things you learn in internal medicine, but those are, I think, the biggest categories. She's depressed, overweight. She has a family history of diabetes, but then they tell you her fasting glucose is not bad. She has a very dilute urine. She's clearly polyuric. So people who tell you I'm polyuric, you have to quantify it. Polyuria is 2 or 3 liters a day or more, not just I feel like I'm peeing all the time. So she gets a water deprivation test. So, probably you've never done this, but a water deprivation test is just literally making sure they're getting no water in any way, shape, or form, measuring sodium, urine, and serum osms on a regular basis, watching them carefully, because if they really do have DI, they can get pretty hypotensive and sick. And then watching as their urine gets more and more dilute, despite the fact that their serum is getting more and more concentrated. Like, so a normal person would start to hold on to some of that water eventually. So her serum sodium rises to 148, urine osmolality stays very dilute, under 300, and her plasma osmolality rises to 299, and that's what the test has to end at. You have to get your serum concentrated to 295 or 300. Okay. So the urine output remains 275 an hour. They collect blood for ADH, which is, we don't often do that. It takes weeks and weeks to come back, and it's not a very good test, but they did it. They gave her a microgram of vasopressin, and then her urine osmolality increased, and her urine output decreased. And the blood antidiuretic hormone is still pending, and it will be pending for like 4 or 5 weeks. So what do you think is going on here? C, central diabetes insipidus. Yeah. In real life, there's a lot of overlap between central and nephrogenic, unfortunately. We get a lot of in-between values, but on the boards, they should respond beautifully to vasopressin, or they should respond not at all, in which case they have nephrogenic DI. Okay. What would primary polydipsia look like if you deprived her? She would be able to concentrate? Yeah, she would. Her medullary gradient would be a little washed out if she was someone who'd been drinking, 10 liters of water a day for years and years and years. So it would take a little longer to concentrate, perhaps. But the most important thing is her serum. Her serum would never get to 305, 310, 320, or sodium would not get to 150. So it may take her a while to concentrate her urine, but she would never make herself hypernatremic and hyperosmolaric, whatever the word is. So that's good. They would respond. It's just not as robust as a normal person. Okay, this might be my last pituitary. So this is a 38-year-old man who has fatigue, low libido, and he also has headaches for 2 years. So he has the classic bitemporal visual field defect. The exam confirms it. He has small, soft testes. So normal testicle size is 15 to 20 cc's.